or maturation of the thyroid stimulating hormone. So different genes are should be expressed, alpha subunit and beta subunit, and it also promotes secretion of prolactin and growth hormone. So this is about the thyroid hormone releasing hormone. And thyroid stimulating hormone, which is secreted from the thyrotropes from the anterior pituitary. The functions of the thyroid stimulating hormone, it includes the entry, it helps the entry of the iodine into the thyroid gland cell, that is known as the iodide trapping mechanism. So iodide trapping mechanism is through the protein structure known as the sodium iodide symport, and then iodide binding mechanism, then the synthesis of T3 and T4, and secretion of thyroglobulin into the colloid region after the synthesis into the thyroid gland cell, and endocytosis. This thyroglobulin and all the molecules, they are entered into the colloid region. Thyroid stimulating hormone also increases the blood supply to the thyroid gland, and it also increases the size and number of follicles that you can see in this slide. It increases the size and number of follicles. Therefore, chronic rise in thyroid stimulating hormone causes the thyroid hypertrophy or goiter. So this is about this thyroid stimulating hormone. And thyroid stimulating hormone is acting onto the thyroid gland cell. Just I'm repeating, in 5 minutes we will cover it. So thyroid stimulating hormone receptor is present onto receptor. This is the thyroid stimulating hormone receptor onto the thyroid gland cell, and it activates the adenylyl cyclase through via GS protein, that is the second messenger system, and it also acts through phospholipase C system. So ultimately what will happen, this will lead to the increases the function, synthetic function, and the secretory function of the thyroid gland cell. Now we have to see, before we see the functions of the thyroid hormone, we have to see the structure also I have told you last time, MIT, DIT, T3 and T4. Now we'll see normal concentration of the thyroid hormone into the plasma, then we'll see the functions. Before we see the normal concentration. So normal concentration of the thyroid hormone in the plasma is about 15 microgram per deciliter. Free T4 level in the plasma is about 2 nanogram per deciliter. This is in nanogram, not in microgram, it is in nanogram. And free T3 level in plasma is about 0.3 nanogram per deciliter. Now total plasma T4 and free T4, what is the difference behind this? The total plasma T4 is the total concentration of the T4 in the plasma is free form plus bound form. Both together it is total. And free form is important over here for the negative feedback mechanism. Bound form is in the form of bound form is mainly for the reservoir over here. So ultimately, this both the conditions, they are both the situation, the availability of the thyroid hormone. So first, what will happen whenever the thyroid hormone secretion takes place? It binds with the plasma protein. When the saturation occurs, then the free concentration will start to rise. Now the thyroid binding globulin. What is thyroid binding? Binding proteins are there. The binding and its importance. The thyroid hormone has to bind with these binding proteins. Thyroid binding globulin, the TBG. The thyroid binding globulin is a glycoprotein synthesized by the liver. This is synthesized by the liver, and molecular weight is 54,000. So it is synthesized by the liver. Molecule has a single binding site for molecule of thyroid hormone. Now, about this protein structure, thyroid binding globulin. Now, with this molecule, the T4 is binding with this and T3 is also binding with this. So T3 and T4 both are binding with this. Out of this, 70% of T4 is binding with the thyroid binding globulin and 45% of T3 is binding with thyroid binding globulin. Now in physiological condition, one is the pregnancy. The thyroid binding level in plasma increases in pregnancy and patients receiving estrogen or major tranquilizers. In this condition, the thyroid binding globulin level is increased. So you have to remember the TBG, thyroid binding globulin level is increases during pregnancy. So during pregnancy, the TBG is synthesized more, so more bound form is available and free form concentration is not rising to the atmosphere level. That's why the negative feedback mechanism will not work here. Only it works when there is a saturation comes for the binding form. Next, the plasma thyroid thyroxine binding globulin level is decreases. In which condition it is decreases? It decreases in which the patients receiving the glucocorticoid, androgens, and some chemotherapeutic drug, cancer drug. So these are the conditions in which the TBG level decreases. The patient receiving the glucocorticoid and glucocorticoid is given to the patients who is undergone surgery or tissue transplantation, and even an androgen also. The TBG level is decreases, and the people who receive suffering from cancer receiving the cancer chemotherapeutic drugs. So these are the thyroid binding globulin. Next is the thyroid binding prealbumin, TBPA. Thyroid binding prealbumin. This is also known as the transthyretin, and this transthyretin, uh, this is not an albumin, it is a globulin. That's why this is known as a transthyretin. And binding of T3 with thyroid binding prealbumin is very less and about 1%, and 20% of T4 is binding with this thyroid binding prealbumin. And third binding protein is the albumin. Now this albumin, around 55% of T3 is binding with this. Mainly this T3 is binding with the albumin, and 10% of T4 is binding with the albumin. So the concentration of free T3 and T4 depends on the concentration of plasma protein that binds these hormones. So plasma protein concentration is important over here, and function of the liver is also important. So whenever there is a liver abnormality, there will be affecting the binding protein concentration. So when the concentration of thyroid binding protein increases in plasma, the free level of the thyroid hormone decreases. So because most of the hormone which is secreted decreases, secreted is binding with the binding protein, so ultimately the free form concentration is less, and that's why the feedback signals are also decreases to secrete more thyroid stimulating hormone. So feedback signal is decreases, more TSH, and this in turn increases the secretion of the thyroid hormone. Now, importance of binding with this hormone. Number one, It serves as a reservoir. Number two, protects the hormone against metabolic degradation. And number three is a feedback effect on regulation. So there are the three important uh, things are there. The hormone which is binding with the binding proteins. So the secretion is decreased or metabolized, is increased suddenly and temporarily. When the hormone is binding with the binding protein, the the degradation of the hormone and metabolized of this hormone is decreases. So ultimately, the concentration of bound form in the plasma is increases. So that will function as a reservoir. And this binding protein also helps for the molecules to protect the hormone against metabolic degradation. So half-life of this hormone is increasing. So circulating T3 and T4 life is increases, half-life is increases. So T3 half-life is 1 day and T4 half-life is 7 days. And the remaining free form concentration, which is required for the feedback effect on regulation. So free form concentration is less, the feedback effect on regulation is also less. So concentration of free form is increases, there will be a negative feedback concentration. So now the action of the thyroid hormone. Now before that, we'll see. Okay, we'll see later on after the functions. Now mechanism of action of the thyroid hormone. This is the slide which I'm going to show you. This is the slide in which, or if there is a yes, this also slide you can understand this, but I'll explain both together here. Now how this thyroid hormone, what is the mechanism of action of the thyroid hormone? Now before that we have to see the thyroid hormone receptor. So thyroid hormone receptor, the structure, there are the alpha and beta subunit. The alpha receptor gene is located on chromosome 17. Just a minute, just okay. So thyroid hormone receptor, just I'll explain the thyroid hormone. What is thyroid hormone receptor? TR, it is known as also TR. There are the two human genes, alpha and beta. Alpha receptor gene is located on chromosome 17 and beta gene is located on chromosome 3. So two different mRNAs are formed and therefore two different receptor proteins are formed. TR alpha 1, TR alpha 2, TR beta 1, TR beta 2. So four different receptor proteins are formed over here. So TR alpha 1, TR alpha, TR alpha 1, TR beta 1 and TR beta 2 binds with T3. Alpha 1, beta 2 binds with T3 and TR alpha 1 and TR beta 1 widely distributed into the tissues. TR alpha 2 does not bind with the T3 and widely distributed and its function is still not known. So this is the structure over here of the thyroid hormone receptor. Now TR alpha 1, it is widely expressed in different tissues, mainly in the cardiac and the skeletal muscles, and TR beta 1 expressed in brain, liver, and kidney, and TR beta 2 found in hypothalamus and pituitary gland. So this is the thyroid hormone receptor. and T3 binds more rapidly and avidly to thyroid receptor, and therefore T3 is more potent to T4. So T3 is very rapidly binding with T3 in myocytes, in muscles, especially in heart. The T3 is not formed from T4. So T4 is not converted to T3. So T3 directly enters the myocytes to combine with nuclear receptor. Here, this is the nuclear receptor and express or inhibits the gene. Now, this is the thyroxine binding protein uh, bound form is there, and this hormone is, this molecule of this hormone is entering into the cell in the cell cytoplasm. Now T4 is converted to T3 with deiodinase enzyme. Now this also I'm going to explain you what are the types of the deiodinase enzyme. Okay, let me complete this deiodinase enzyme. Just a minute. Yes, this is the deiodinase enzyme. This is the structure of the T4. Now T4. Now here you can see the deiodinase enzymes are there. The deiodinase enzyme, this is removing the iodine from its binding sites and make T4 to T3. And then T3 again deiodinase converted to T3 to T2, and then another deiodinase enzyme converted T2 to T1 and ultimately thyrolene. So iodine is separated and thyrolene is also separated. So ultimately both the enzymes, either it is uh, 3 days and 5 days, one by one, the iodine is removed by the deiodinase enzyme, and also the at 3 plus and 5 days, deiodinase enzyme is removing the binding site. Ultimately, what will happen? This converted to T3, T2, T1, and T0. If the place 3, if it is removed, now structure I am telling you. Now here you can see the structure here. Here you can see the structure monoiodotyrosine MIT. Now here you can see the T3 and uh, T3 and T4 is there. Now one iodine is removed at the place at the T5 place. Then this structure is converted to RT3, reverse T3. Just a minute, I'll show you. Okay, you can see from the book because in biochemistry you must have seen. Now this deiodinase enzyme is removing the iodine from its binding site, and ultimately that will lead to degrade the structure of this iodine. Now this how peripherally it is degraded. These deiodinase enzymes are of three types. Now three types deiodinase enzyme. Uh, Three types of deiodinase enzyme are there. Number one is D1, number two D2, and number three D3. D1 is also known as type 1, D2 is also known as type 2, and D3 is also known as type 3. Now this deiodinase enzyme is removing the iodine from T3 and T4, and ultimately it is converted to at the last to thyrronine. This is the thyrronine. So this is the T4 structure is there. T4 structure, when one iodine is removed from the 5 days place, then this will be a T3 molecule. But if it is removed from 5 place, then it will be converted to RT3. Now difference between the T3 and RT3 is T3 is most potent biological active form, and RT3 reverse T3 is not in biological active form. This is non-active form is there. So if the dehydrogenase enzyme is removing from the place of 5, then it will be a non-biological active form of T3 known as the reverse T3. But if it is iodine is removed from the 5 days place, then it will be converted to most biological potent form is there. And then further it is removed at 5 days, then 3 days, then it will be T2. This is non-functional form. This is also non-functional form, and RT3 also converted to non-functional form, and finally only one iodine is remaining. That also again removed by the dehydrogenase enzyme, and finally iodine is freely available in the plasma, and thyrosine is also available in the plasma freely. So that thyrosine is again reutilized by the gland itself. Now D1, where the D1 is present. Type 1 type of the dehydrogenase enzyme. There are 3 types of dehydrogenase enzyme: type 1, type 2, type 3, or D1, D2, and D3. So D1 is present in liver, kidney, thyroid, and pituitary. D1 is present in, okay, just let me search the slide. Yes, dehydrogenase enzyme. This D1, D2, and D3, type 1, type 2, and type 3. The D1 is present in liver, kidney, thyroid gland, lungs, and the eye. D2 is present in brain, myocardium, skeletal muscle, and brown fat tissue. And D3 is present in liver, skin, brain, and the placenta. So D1 and D2 are 5 days dehydrogenase enzyme that convert D4, D1, and D2. These first two. This dehydrogenase to 5 days place. So ultimately it convert to T3. That is the most potent biological active form to maintain the level of intracellular T3 for target tissue. And T3 promotes the conversion of T4 to RT3, and RT3 is least biological active or non-biological active form is there. And T2 in the brain, T2 type 2 dehydrogenase enzyme in the brain is maintain the supply of T3 to the neurons. So this thyroid hormone is required for the central nervous system, most important while the brain is developing. And T3 is then after that the T3 is degraded, diiodothyronine and dehydrogenase that are present in liver and the kidney, that will be again degraded from T3 to T2 or RT3 to T2. So in liver it is metabolized, conjugation with sulfates and glucuronides, and finally it is secreted in the bile into the intestine, and that to re-enter into the enterohepatic circulation. So the iodine is lost minimally about 4% in the stool. So iodine which is taken to the diet, the loss to the stool is around 4%, very, very minimal. And many tissues T4 is also metabolized to tetraiodoacetic acid tartrate. So this is about the dehydrogenase enzyme. Now we'll see the function of the thyroid hormone. The function of the thyroid hormone before, yes, uh, we'll see the physiological action of the thyroid hormone. Are you able to listen? Are you getting my voice? Now first we'll see the general effect. Overall, what is the effect of the thyroid hormone onto the peripheral tissues? The thyroid hormone controls the basal energy metabolism, development of the central nervous system, and normal body growth in childhood. This is the important function is there. Now we'll see the General effect on metabolism. Now here in general effect of metabolism, this is the general cell is there, peripheral tissue is there. This peripheral tissue, this thyroid hormone is targeting to the cell. Now this is the, already I have told you that in the previous class that thyroid hormone and steroid hormone, they have the receptors onto the nucleus in the cell itself, not in the cytoplasm. But other hormones, they have the receptor onto the cell membrane. So there are the types of the receptors already. Second messenger system we have already studied. Now this is thyroid hormone directly enters into the cell cytoplasm, converted T4 to T3 by deiodinase enzyme, and this T3 is most biological active form enter into the nucleoplasm nuclear and target to the thyroid response element. It binds it where the thyroid hormone receptor is available. So ultimately, after binding this, the conformation change takes place, and that will lead to the expression of the gene, and ultimately many mRNAs, tRNAs are formed, and ultimately this transcription will lead to the formation of the many varieties of the structures through the mRNAs. Now, this thyroid hormone, the thyroid hormone, how it will work. The metabolism of the cell depends on oxygen consumption. So oxygen is essential for the phosphorylation of ATP to ATP that makes the makes that place in mitochondria. So the mitochondria is the most important organ where the nutrients are utilized, oxygen is utilized, and waste products are produced, carbon dioxide is produced, and ultimately this will lead to increase the heat or body temperature into the individual. So thyroid hormone basically what it will do. These mRNAs are formed, they have the different functions are there. These different functions. Number one, how this thyroid hormone is producing these all types of the mRNAs for the different system to work over here. The thyroid hormone increases the basal rate of oxygen consumption. So the thyroid hormone increases the utilization of the oxygen, utilization of the waste nutrients. Ultimately, the consumption will take place, and that will lead to increase the metabolism, increase the rate of heat production. So this is called the calorigenic or thermogenic effect of the thyroid. So that I will show you over here. This is the thyroid hormone which enters after the deiodination in the nucleoplasm, binds with the thyroid response element, and ultimately many messengers are formed, and these messengers, it increases the mitochondrial activity, internal respiration enzymes are increased. Ultimately, that will use the oxygen and the nutrients over here. So it increases cellular metabolism is activated by increase the sodium potassium ATPase. So here in this slide you can see the sodium potassium pump. So sodium potassium pump, this is the protein structure which is established into the cell membrane. This is the thyroid hormone which target to the gene. Ultimately this synthesis of the sodium potassium pump and then recruited into the cell membrane. So ultimately the density of the sodium potassium pump, recruitment and density of the sodium potassium pump is required over here for the normal cell function. So increase the oxygen consumption by the cell parallels there, increase the sodium potassium activity. So decrease the oxygen consumption will inhibit the sodium potassium pump into the cell membrane. This stimulates the T3 also stimulates the transcription of gene for both alpha and beta subunits for sodium potassium pump. So you know the structure of the sodium potassium pump, alpha and beta. So both these structure are synthesized, and ultimately that will lead to mature the protein structure which is recruited. And it also increased oxygen consumption stimulated by thyroid hormone mediated by sodium potassium ATPase activity. So this is targeted. This type of the function, this type of the physiological action is targeted to almost all the tissues of the body, mainly skeletal muscle, liver, heart, kidney, and connective tissue. And certain tissues are there which are not utilizing this thyroid hormone that I'll tell you in the next slide. Uh, the next function is the gluconeogenic enzyme, which is into the liver tissues, increases the functions of this hormone. Ultimately, the gluconeogenic process will continues goes on. Respiratory enzymes mainly in the mitochondria. This is cytochrome system is there that a number of enzymes are synthesized and increase. Ultimately, the nutrient and oxygen are utilized. The myosin heavy chain into the skeletal muscle, beta adrenergic receptors into the cardiac tissue, and many other different functions that we'll see in the system wise. So the target tissues, almost all the tissues are there except a few tissues. Some few tissues in function side reduce, which are these few tissues are there, and this in general, what will happen? This increases finally the oxygen consumption to almost all the cells and nutrient utilization of almost all the cells, and ultimately it increases the uh, thermogenic effect into the body, and it increases the calorigenic or thermogenic effect on the body. So ultimately what will happen, the waste products are produced, so that is the main general function of the thyroid hormone in generally in all the tissues. Now the basal metabolic rate, normally the oxygen consumption at resting state, it is about 250 ml per minute. 250 ml per minute. But when the thyroid hormone level is increases, it is about 400 ml per minute. It increases the basal metabolic rate about 80% plus 80% to the normal situation when the thyroid hormone level is increases, and thyroid hormone level is increases when there is a hyperthyroid condition. And when there is a hypothyroid condition, the oxygen consumption is decreases, the BMR is decreases, and it is, you can say it is minus 40%. So basal, it is 250 ml per minute it is used in the normal individual. In hypothyroid condition, there is a 400 ml per minute the oxygen is utilized, and uh, around 250 to less around 150 ml per minute the oxygen is utilized in the hypothyroid state is there. So increase the BMR, increases the finally increase the BMR, increases the body temperature. So main target is the thyroid hormone onto the general tissue is the mitochondria. And in mitochondria, this all the enzymatic activity for utilization of the nutrients and the oxygen will takes place. So that it will cause to the oxidative phosphorylation, and that it will cause to the stimulate the synthesis of uncoupling protein UCP1, and it also increase and improve the expression of the uncoupling protein 2 and uncoupling protein 3 in you can read in the biochemistry. The metabolic or thermogenic effect of this thyroid hormone, it increases the nitrogen excretion because of the metabolism is increases. So the nitrogen protein metabolism will lead to increase in the nitrogen excretion. So that will, how it will happens, it increase the food intake associated with the hypermetabolic state, prevent catabolism of endogenous protein and fat. That will lead to significant weight loss, occurs promptly increase thyroid activity, and without adequate nutrient supplementation. Second thing is it increases the body temperature. So when the body temperature is increasing, it causes the vasodilation that decreases the peripheral resistance, and consequence changes occur in hemodynamics. And third, it increases the requirement for vitamins. So vitamin deficiency is common in the increased thyroid activity. So these are all the general effect is there of all the tissues are there. So now we'll see one by one system wise. So you can see over here in this slide the oxygen consumption that will lead to the system to cardiovascular system and respiratory system, because oxygen is required. So transportation of oxygen plus ventilation. At the peripheral level, in the mitochondrial level, in the all gender tissues, the food that will lead to the increase the food intake, mobilization of endogenous and carbohydrate, protein and fat, all the nutrients, and metabolic rate. When the metabolic rate is increases, all the enzymes are functioning. Ultimately, that will lead to the waste products like carbon dioxide. And when carbon dioxide is increasing, it will increase the ventilation, increase the urea, increase the renal function, decrease the muscle mass because of the protein catabolism, decrease the adipose tissue, lipolysis takes place, and it increases the body temperature. And when the body temperature is increasing, that will lead to the sweating and vasodilation, and increases the insensible water loss. Insensible water loss means the water is losing from the body, which cannot be measured. So these are the how in general, in outline, the function of the thyroid hormone. Now we'll see all the functions system wise. Yes. Now here we can see all the system wise in detail. We'll see. First is the metabolic activity. Metabolic activity, it increases in the, I have already explained in detail that we need to increase the consumption in all the tissues. Except a few tissues. Which are these few tissues are there which are not utilizing the thyroid hormone? These tissues are, you can see the list, the entry pituitary, adult brain, gonads, testes and ovary both, uterus, lymph nodes, spleen. So this tissue does not show the thermogenic response. That's why this thermogenic response is not required by this tissue. That's why the thyroid hormone is not utilized by these tissues are there. So all other tissues they utilize the thyroid hormone. So you can make a list: the entry pituitary, adult brain, testis, ovary, lymph nodes, spleen. These are the tissue does not use the thyroid. And receptor for the thyroid hormone in adult brain is almost absent. So this is the difference between the developing brain and the adult brain. The developing brain, the receptors for the thyroid hormones are there, but in adult brain, the receptors are almost absent. So this is the difference. Now we'll see one by one of the function of the thyroid hormone. First, we see the cardiovascular effect, the function of the thyroid hormone on cardiovascular parameters. The thyroid hormone increases the heart rate and myocardial contractility. Therefore, it increases the cardiac output. So, main function of the thyroid hormone on the cardiovascular parameters are there. It increases the cardiac output. Now, in the cardiac output, you can know the definition of the cardiac output. That is the amount of blood pumped by the ventricle per minute. So there are the two parameters are there. First is the heart rate and myocardial contractility. So here first we'll see the heart rate. Thyroid hormone increases, the thyroid hormone increases the number of beta receptors. Thyroid hormone increases the number of beta receptors on nodal tissue. Nodal tissue means SA node and AB node. So nodal tissue, SA node and AB node. So it increases the beta receptor. And it also increases the sensitivity of beta receptors to catecholamines. In adrenal medulla, we'll see. So it increases the sensitivity of beta receptors, plus it increases the number of beta receptors. So the density of the beta receptors are increases at the level of the nodal tissue, plus it increases the sensitivity of beta receptor to catecholamines. And catecholamines are, these are the epinephrine, norepinephrine, and dopamine. So epinephrine and norepinephrine is important over here. So ultimately what will happen? Thyroid hormone will increase the heart rate because the beta receptor activity increases. And that's why in the hyperthyroidism, the heart rate is increases because of the beta receptor and its sensitivity, and that's why the tachycardia you can see in the hyperthyroid patient. This is on the nodal tissue. Then on myocardial contractility, that means the cardiac muscle, this number one, the thyroid hormone induce the myosin heavy chain. MHC, myosin heavy chain expression, gene expression to myosin heavy chain. So ultimately what will happen? That will lead to the alpha MSH activity, alpha MSH particularly for the myosin heavy chain, which is the synthesized contractile protein into the cardiac tissue, and which has more actin and calcium activated ATPase activity. So ultimately contractile protein is synthesized and established over there for increases its activity. And thyroid hormone also expresses the beta receptors, G protein, and sodium potassium activity in myocardial cells. It also increases the beta receptors, G protein. This is for the secondary communication system, and sodium potassium pump in myocardial activity. That in general metabolism I have already told you. And this also increases the calcium ATPase activity. This also increases the calcium ATPase activity of sarcoplasmic reticulum in cardiac muscle, because the calcium is most important for the cardiac muscle plateau. When the action potential is recorded, you can see the plateau. So that here calcium potassium activity is required, is important over here, which facilitates the sequestration of calcium. So all these factors, the contractile protein, calcium ATPase activity, sodium potassium pump, expression of beta receptors, and G protein structure, which all together will lead to increase the stroke volume. So ultimately the heart rate is increases, and ultimately the stroke volume is increases. I think I should show you this, the direct and indirect effect. So MHC, myosin heavy chain, here before that, let me complete the first one, then we'll see this slide. The myosin heavy chain in heart muscles, there are the two types of heavy chains, are the alpha and beta. You must have learned in the cardiovascular system. Alpha MHC is high myosin ATPase activity, and beta MHC has a low myosin activity. So thyroid hormone stimulates the alpha MHC, which has got the high myosin activity, inhibit the beta MHC activity. So ultimately, low myosin ATPase activity is suppressed by thyroid hormone, and high myosin ATPase activity is stimulated. So hyperthyroid person, what will happen? Expression of alpha MHC gene is enhanced and beta is suppressed. So that will lead to the thyroid hormone inhibit the phospholamban. That also I'll show you the slide. Phospholamban activity, adenylyl cyclase, T3 and nuclear receptors, and calcium sodium exchanger, or you can say the sodium calcium exchanger. And this is about the myocardial activity. And number three, because of the heart rate and the cardiac output, or heart rate in the and the stroke volume is increases, that will increase the systolic pressure, and this heart rate and stroke volume will result finally to cardiac output. So systolic blood pressure increases significantly, and in diastolic blood pressure, that through the calorigenic action, thyroid hormone increases the body temperature, that causes the thermogenic cutaneous vasodilation and decreases the peripheral resistance. So finally, what will happen? Pulse pressure, diastolic pressure is decreases, systolic pressure is increases. It increases the heart rate, it increases the stroke volume. So all four parameters you can list it. Pulse pressure and circulation time. The net effect on blood pressure is increased, and pulse pressure increase the pulse pressure. So finally, the stroke volume is increases, systolic blood pressure is increases. Now here the systolic blood pressure is increases, and diastolic blood pressure is decreases. That will wide the pulse pressure. Increased cardiac output and vasodilation makes the circulation hyperdynamic, and therefore the circulation time is short. Now here the all parameters I have explained. Now how the direct and the indirect effect is there. This what is the direct effect? Cardiac muscle. On the cardiac muscle, MHC activity, alpha MHC activity is increased, sodium potassium ATPase activity is increased, calcium ATPase activity is also increased, and G protein is activity is increased. So ultimately, this will lead to the increase the cardiac parameters. Beta MSC activity is suppressed by thyroid hormone, and beta adenine receptor is also suppressed over. So ultimately, this will lead to increase the myocardial activity. It will increase finally the stroke volume. So that will lead to increase the ventricular contractility and function, and because of this, it will decrease the peripheral vascular resistance. So this is the direct effect is there, and indirect effect is heat production in the peripheral region in all general tissue. They are different all the tissues. The utilization of the nutrients and the oxygen at the level of the mitochondria, the heat is produced, carbon dioxide is produced, so that will lead to the peripheral vasodilation. So peripheral vascular resistance decreases. That will lead to the diastolic blood pressure decreases, and that will lead to the circulation time short. So ultimately, what will happen? Finally, this will lead to the increase the cardiac rate and output. So pulse systolic pressure is increases here, diastolic pressure is increases here, pulse pressure is widening, and because of the thermogenic effect, the vasodilation occurs, and that will lead to finally the cardiac output, cardiac rate and cardiac output. Ultimately, it increases the blood volume. So this both the direct and indirect effect will lead to the function of the cardiovascular parameters. So this is how the thyroid hormone act onto the cardiovascular parameters. Now second is central nervous system. Now here is central nervous system. It is very important. On the central nervous system, here it is written the brain development. Now I am explaining in detail you what how this thyroid hormone is helping for the brain development. Thyroid hormone is essential for the development of the brain, central nervous system, particularly during the developmental phase of life, during the fetal life as well as infancy and in childhood. This is the most important period till the puberty ends. This thyroid hormone is most important for the development of the brain. And out of this time period, right from the fetal life to the puberty is completed, out of this, the most important crucial time period for the thyroid hormone to develop the different central nervous system areas is the during infancy and early childhood. That is most important. And out of this, the 6 months after the birth and 6 months before the birth. That means second trimester, during pregnancy, second trimester and third trimester. This is the 6 months time is very crucial. And after the birth, another 6 months. That is the total 12 months period. Total 1 year time period is most important for the child for the development of the brain. After that also the thyroid hormone is required for the development of the brain, but this is the most crucial time for the development of the brain into the individual. So you have to remember that the 6 months before and 6 months after the thyroid hormone is very crucial for the development of the brain. So during this period, thyroid hormone initiates and facilitates the process of differentiation and maturation of the brain cells. Differentiation and maturation of the brain cells. This is the most important during the fetal life, before birth 6 months, and after birth 6 months the development. Now, how this thyroid hormone is helping for the neural functions, because when there is a development occurs, then the neural function will be there. Now, this number one, the growth of cerebral and cerebral cortices, all the cortices and basal ganglia, all these structures in the brain, all the different types of structures in the brain, all the lobes, they are developed under the influence of the thyroid hormone during this period. The cerebral cortices, basal ganglia, and all other different structures. Number two, it helps for the proliferation of axons and branching of dendrites. It helps for the proliferation of axons and branching of dendrites. So it increases the size of the neuron. So soma is increases in size, number of dendrites are increases, the axon diameter and length is increases, the number of pedodendria are increases. So ultimately what will happen? The anatomical structure of the neuron is increases. Along with that, the functional aspect of the neuron is also increases. So this will lead to the development of the synaptic connection. This synaptic connection will lead to the development of the neurotransmitter system in the central nervous system. So synthesis of the enzyme, these synthesis of the enzymes are essential for the production of the neurotransmitters. And this increase the number of receptors on various neurotransmitters in different tissues of the brain, because enzymes levels are increases, synthesis of the neurotransmitter will be there. So ultimately the receptors for the neurotransmitters also increase into the other neurons. So ultimately, this will lead to the increase the functional aspect of the brain. Then it also helps in the myelination of the neurons. The thyroid hormone stimulate the galactosylceramide transferase activity. So for the myelination of the neuron, the enzyme which is required, all the enzymes are synthesized under this influence of the thyroid hormone, which is essential for the myelin formation. The synthesis of protein and various enzymes also required for the energy generation in neurons. And these substances are the succinate dehydrogenase activity. So that will lead to the energy production into the neuron for its synthesis of the protein and the types of the enzymes which are required. Then it also helps in the cell migration during the brain development, and it also ultimately it will goes to finally general alertness and responsiveness to various stimuli. So ultimately what will happen, the anatomical aspect and the physiological functional aspect, when it is matured, then this will lead to the normal function of the brain to developing, while developing to the milestone of the infants and the early age of childhood, that will lead to the alertness and responsiveness to various stimuli. And ultimately that will lead to the speed and amplitude of the stretch reflexes. So all the physiological aspect will start now, the speed and the amplitude of stretch reflexes, and that finally will lead to the memory, learning, and intellectual capacities. So these are the important function of the thyroid hormone on developing brain. So during infancy, the thyroid hormone is highly essential for the brain development during first year of life, and this deficiency will lead to underdevelop the brain tissues, and that will lead to the retardation. So ultimately that's why the thyroid hormone is most important over here. This is during the infancy, but now what will happen in adult? In adult, the thyroid in adult, what will happen? The cerebral blood flow, glucose, and oxygen utilization by brain remains normal. The thyroid hormone enters in the brain in adult and found in gray matter of various parts of the brain, and T4 is converted to T3 by astrocytes in the brain in the adult. And the type of the deiodinase activity is the type 2, or you can say the D2 type of deiodinase activity is there, and this will help for the thyroid hormone to function onto the astrocytes. Now then, bone and next function is the bone. This it helps for the skeletal development, and it increases the growth, it increases the activity of the cells which is required for the development of the tissues, particularly to the uh, chondrocytes over here. So whenever there is a bone development occurs, there will be a skeletal development which also occurs. And skeletal muscle, again, there is the same expression of the myosin heavy chain gene in the skeletal muscle that will goes to be expressed over here, that will lead to the development of the protein synthesis, and ultimately finally the contractile protein is synthesized, and that will lead to the development of the settlement of the sarcomeres, increases the muscle length as well as the diameter of the muscle fiber is there. In the growth, particularly in the growth, uh, the normal growth and musculoskeletal system both together now we'll see. This will lead to the expression of gene of growth hormone, this thyroid uh, hormone, which stimulates the growth hormone also, that already I have told you on the somatotrophs, that is the thyroid hormone releasing hormone. Ultimately what will happen, that will stimulate the growth hormone secretion and also facilitate the effect on the growth hormone on different tissue. So ultimately that will lead the growth hormone releasing hormone stimulates the somatotrophs in the antipituitary to synthesize and release the growth hormone. But thyroid hormone releasing hormone also stimulates the somatotrophs to synthesize and release the growth hormone. So ultimately, the function of the growth hormone in both the aspects will lead to the normal growth of the tissue. So ultimately, this thyroid hormone also stimulates the linear growth of bones, that already explained into the function of the growth hormone, that will for the endochondral ossification and maturation of epiphyseal bone. So how this epiphyseal endochondral ossification and maturation of epiphyseal bone centers, that will increase the activity or enhance the activity of the chondrocytes, and it increases the osteoid activity. And this thyroid hormone is also responsible along with the growth hormone for the eruption and development of the teeth. It also, along with the growth hormone, the thyroid hormone helps for the promote epidermal growth of nails and hairs, and it stimulates the synthesis of structural and enzymatic proteins. So ultimately, what will happen? These all the activities under the influence of the thyroid hormone releasing hormone, stimulate the somatotroph, increases the growth hormone, that will increase the growth of in the individual and to the general level. So whenever there is a deficiency of thyroid hormone releasing hormone, the enough stimulation to the somatotroph will not be there. Ultimately, the thyroid hormone hypothalamic failure will lead to the not a proper growth of the individual. Now, in the skeletal muscle, I have already told you that it expresses the MHC gene, and higher in concentration will lead to the protein catabolism. So, within the physiological range of the thyroid hormone will cause the protein anabolic activity, but when there is a hyper activity of the gland, the hyperthyroid condition, there will be a protein catabolism occurs. And in hypothyroid condition, the protein anabolic activity will be suppressed. Ultimately, the protein synthesis will not be up to the mark. Ultimately, muscle development and the power generation will be less. So, in hypothyroid condition, because of the less anabolic or suppress of the anabolic activity, the muscle development will not be there, And in hyperthyroid condition, the protein catabolic activity will lead to the weakness of the muscle. So here, within the physiological range of the thyroid hormone, will have the normal muscle power. But when there is a hypothyroid condition, weakness occurs, and when there is a hyperthyroid condition, because of the protein catabolism, again there is a muscle weakness. So muscle weakness occurs in the individual, the hypothyroid as well in the hyperthyroid situation. Then adipose tissue. So when we study about the adipose tissue, I'll tell you about all the intermediary metabolism. That means the carbohydrate metabolism, fat metabolism, and protein metabolism. So carbohydrate metabolism, adipose tissue, it is written. So before I tell you the it increases the lipolysis. How it increases the lipolysis? On fat metabolism, it stimulates the lipolysis. So how the thyroid hormone increases the lipolysis? It releases of free fatty acids and glycerol from adipose tissue, and that glycerol is utilized for the gluconeogenesis. This is number one. Number two, it increases thyroid hormone increases the turnover of lipids by facilitating their oxidation. And number three, it stimulates the synthesis of cholesterol and simultaneously promote its oxidation and biliary excretion. It stimulates the synthesis of cholesterol and that promote its oxidation and biliary system. Also, cholesterol is increased. The hepatic uptake of cholesterol is increased by increased expression of LDL receptors in the liver, and therefore what will happen? A significant decrease in plasma cholesterol and total lipid. So here two contradictory effects are there. The thyroid hormone on adipose tissue, it increases the lipolysis. That means it increases the plasma free fatty acid level. Plasma free fatty acid level. But this free fatty acid and glycerol is removed by the hepatic tissue by increases the LDL receptors. So ultimately that free fatty acid is taken up by the liver cells. So the plasma concentration of free fatty acid is decreases. So ultimately overall effect of thyroid hormone is lipolysis. It increases the lipolysis, but at the plasma level, the significant decrease in the plasma cholesterol level and ultimately total lipid. On protein metabolism, it promotes the proteolysis in skeletal muscle, increases the because of the proteolysis, it increases and releases the amino acids. So increase protein turnover by promoting protein degradation. So higher in concentration of the thyroid hormone goes to the protein catabolism in skeletal muscle, and lower concentration of thyroid hormone, the anabolic activity will not take place up to the mark. On carbohydrate metabolism, it increases the absorption of the glucose from intestine. So how it will increase the absorption? Number one, it increases the hepatic glucose output. It increases the hepatic glucose output by inducing gluconeogenesis and stimulate the hepatic glycosenolysis. So that will lead to increase the plasma glucose level, and this increased plasma glucose level by increase its uptake and oxidation, and net effect is no substantial changes in plasma glucose concentration. So how this is happen? Hepatic glycosenolysis. Increase hepatic glucose output by including gluconeogenesis. So stimulate the hepatic glycosenolysis. Therefore, the plasma glucose level is increases. But increase the turn of glucose by increasing its uptake and oxidation. Ultimately, from the plasma, the blood glucose level is decreased. So ultimately, the same as the free fatty acid level in the plasma, same as the glucose concentration also is normal in the plasma. So hyperthyroid situation, what will happen? The plasma glucose level rises fast after carbohydrate meal, but decreases rapidly. And that's a sustained hyperglycemia or glucose intolerance is not a usual feature of the hyperthyroid. So when there is a sudden rise of the plasma glucose after the meal in the individual and decreases rapidly in such patients, that will not the cause of glucose intolerance in a usual feature. So some patients develop the glucose intolerance or even diabetes in long run. So this is how the uh, intermediate metabolism. Now in GIT, gastrointestinal tract. In the gastrointestinal tract, this thyroid hormone increases the gastrointestinal motility, and therefore the hyperdefecation is a feature of the hyperthyroidism, and constipation is the feature of the hypothyroidism. So the thyroid hormone is increases the so hypothyroidism. Sorry, uh, the hyperdefecation is a feature of hyperthyroid person because of the thyroid hormones increases the gastric motility, and concentration of the thyroid hormone is less in the hypothyroid patient. It occurs the constipation because the motility of the GIT is suppressed. On reproductive system, in reproductive system, both in male and female. First, we'll talk about the female. The female reproductive system. This thyroid hormone is an important role in regulation of reproductive function. So, in female, it facilitates the follicular maturation and ovulation. So, this is the important part over here in the female, the follicular maturation and ovulation. So, abnormality in female of the this abnormal thyroid hormone abnormality of thyroid hormone is either it is the hyperconcentration or either it is a hypoconcentration. So abnormality in women results in irregularities in menstrual cycle, such condition is known as the menorrhea, increased menstrual loss, and in hypothyroidism, and this will cause to the decreased menstrual loss known as the oligomenorrhea. Sorry, I have done a mistake over here. The in woman result in irregularities in menstrual cycle. The menorrhea, that is the increase in menstrual loss in hypothyroidism, and oligomenorrhea, that is decrease in menstrual loss in hyperthyroidism. Please correct it. So in hypothyroidism, when there is a hypothyroid condition is there, that will lead to increase the menstrual loss, menorrhea, and in hyperthyroidism there is a oligomenorrhea, decrease in menstrual loss. And in males, normally it promotes the spermatogenesis. So T3 promotes the differentiation of prepubertal testicular certolysis. So that is the function of the thyroid hormone in on reproductive systems. Then, okay, then I'll tell you about the respiratory system. It is not written here about the respiratory system, but on respiratory system, uh, the thyroid hormone increase oxygen utilization of tissues. Thyroxine meets this demand by stimulating the rate of respiration. That is, the respiratory parameters are there: rate of respiration, minute ventilation, and ventilatory responses. And ventilatory responses means there are two important conditions are there. One is the hypercapnia, one is the hypoxia. Hypoxia means low O2 concentration. Hypercapnia means higher PCO2 concentration in the plasma. So respiratory parameters, respiratory rate, minute ventilation, and the ventilatory responses to hypercapnic condition and hypoxic condition. Arterial PO2 increases, that increase the supply of oxygen to tissues, because respiratory rate is increases, arterial PO2 level is increases, and this PO2 level is required for the stimulation, required for the utilization by the tissues. And thyroid hormone also stimulates the erythropoiesis. So erythropoiesis, that means the number of red blood cells are increases in the circulation. So total amount of hemoglobin increases finally. Ultimately, more and more oxygen binds with the hemoglobin, and that will lead to fulfilling the supply of oxygen to the tissues are there. That is stimulate the erythropoiesis by increasing the synthesis of the erythropoietin. So erythropoietin stimulates the erythropoiesis, and that will lead to the supply the oxygen to the different tissues. And on kidney, renal system, the function of the thyroid hormone, it increases the kidney size and promote growth of renal tubular epithelial cells. The thyroid hormone is important for the tubular epithelial cells in the nephron. So how it will increase? Number one, it increases the renal blood flow. It increases the renal blood flow. So cardiovascular parameters are increases, systolic blood pressure is increases, cardiac output, stroke volume is increases. So ultimately renal blood flow is increases, and at the level of the kidney, it increases the glomerular filtration rate. So, that will lead to increase the reabsorption of water, electrolytes, and glucose. That will increase by the thyroid hormone. So increase water reabsorption increases the finally increase water reabsorption, increase the glucose will lead finally to the increase in the blood work. So ultimately what will happen at the end? Thyroid hormone have a widespread effect on metabolism, growth and development, and control of many systemic functions are. So this is about the thyroid hormone functions. I think I have covered almost all the systems about the thyroid hormone functions. Then we'll see this is the phospholamban activities that I was telling you about the phospholamban activity on the cardiovascular system. This you can see this here in this slide you can see the phospholamban that will lead to the controlling the activity of the cardiac calcium functions into the cell. So this will what will happen? The catecholamine, the beta receptor increase the sensitivity to the catecholamine, and catecholamine increases the adenylyl cyclase over here. This cyclic AMP and phosphokinases increase the phosphorylates of different enzymes are there. Out of this, one is the troponin 1 and one is the phospholamban. And phospholamban is helps to release the calcium from the sarcoplasmic tubular system, which is not properly developed. So that will lead to increase the ionic calcium concentration into the plasma. So ultimately that will lead to the function of the cardiac myocytes over. So overall you can see the overall, yes. Now you can see in overall all these things. Now the thyroid hormone stimulates which gene to express and which gene is suppressed. So the thyroid hormone is increases all these activities. It expresses the gene for all these. I have made this list is there: sodium potassium ATPase, cytochrome system, alpha glycerophosphate dehydrogenase. These are all the enzymes which is required for the normal function metabolic activity of the cells. Pyridine nucleotide trans hydrogenases, urea, malic acid, calcium ATPase. This already I have explained in the system wise. Myosin heavy chain, that is called alpha. Glucose transporters, beta adenine receptors. Then stimulatory G protein, cyclic AMP, erythropoietin, tyrosine, osteocalcin, alkaline phosphate, hydroxyproline, this is for the bond development, growth hormone, antidiuretic hormone, sex steroid binding globulin, metabolites of cortisol, and thyroid hormone is suppressing the activity of the thyroid stimulating hormone, thyroid hormone receptor, myosin heavy chain for beta creatinine kinase, inhibitory G protein, total, and LDL cholesterol. So ultimately, what will happen finally through this, the thyroid hormone is functioning to all the different tissues in the bodies, particularly increases the intermediary metabolism, growth and development, the developing brain, that is the metabolic and thermogenic effect is there, cardiovascular parameters, the one more system, I think the sympathetic nervous system. In the central nervous system, along with this, I have to tell you about the sympathetic nervous system. The sympathetic nervous system that also responsible for the heat production, rate of increase the rate of metabolism, heat production, heart rate, and neuromuscular functions. So the sympathetic nervous system, that is the metabolic effects of the catecholamine, and catecholamine effects are lipolysis, glycogenolysis, and gluconeogenesis. And that also catecholamines increase the expression and sensitivity of beta receptors in heart and skeletal muscle, even in adipose tissue also. And this will lead to the through the beta 3 receptors, it will T3, the thyroid hormone, stimulates the production of thermogenin in the brown fat. So these are all the parameters are there which you can run. This is the feedback mechanism of the thyroid hormone or regulation of the thyroid hormone. And the regulation of the thyroid hormone, here you can see there are the various effects are there onto the hypothalamus. The circadian rhythm is there, severe stress is there, the acute psychosis and cold is there. So these are the positive effect onto the hypothalamic neurons, and stress is the negative effect onto the hypothalamus. So ultimately, these two important factors are there. One is the thermal and one is the calorie. Calorie means nutrients which are required. The nutrients, the protein, fat, and carbohydrate, vitamins, and minerals. And thermal means the body temperature, internal temperature, and environmental external temperature. That will lead to the signal to the hypothalamus. Ultimately, this will lead to increase the depend upon the bombardment, the thyroid releasing hormone, which target to the thyroid troughs, which release to the thyroid stimulating hormone. Ultimately, the thyroid hormone secretion will take place. This secretion is in two forms, T3 and T4, which binds with the binding proteins. Once the binding protein situation occurs, then it will lead to increase the free concentration of the thyroid hormone. That free concentration will have the negative feedback mechanism to the pituitary level and to the hypothyroid. So this is about the how the regulation of the thyroid hormone regulation. Then we'll see the hypothyroid, hypo and hyperthyroid situation. This you can see the how the deiodinase of the hormone takes place. This is the T4. Type 3 will lead to the T3. This is the type T1 and D2 will convert T4 to T3, and D3 and D1 convert to RT3. Now hypothyroid. Now we'll see the disorders of the thyroid hormone. There are two conditions are there. One is the hyperthyroid condition, one is the hypothyroid condition. First we'll see the hyperthyroid condition. So in hyperthyroid condition, there are the two situations are there of the hyperthyroid condition. One is the primary and one is the secondary. Now what is primary and what is secondary? Primary means at the level of the thyroid gland itself. If there is any abnormality occurs, then this abnormality will lead to the thyroid hormone activity or thyroid gland cell activities increases, and ultimately that will lead to increase the T3, T4 level in the plasma. So that will be based on thyroid gland itself. And if there is a abnormality occurs at the level of the anterior pituitary, then this number of thyroid drops will secrete more TSH, and because of more TSH available and exposed to thyroid gland cell, that will cause to increase the thyroid gland cell activity, and that is known as the secondary uh, type of the hyperthyroidism. So primary type of the hyperthyroidism, number one is the adenoma of thyroid gland cell, multinodular goiter. The goiter will occur because of the I'll show the photograph also. The thyroid gland's size is increases because of the uh, concentration of the iodine in the diet is less. Ultimately, the growth of the thyroid gland will occur, and ultimately more and more uh, number of cells and size is increases. There is a metastatic carcinoma functioning of the thyroid gland. See, metastatic carcinoma, if this type of cells, carcinogenic cells, functioning same as that of the thyroid gland, also that will lead to increase the T2 and Graves' disease. That is the thyrotoxicosis. The increased activity of the thyroid gland cell will lead to the increased secretion of the thyroid hormone in the plasma and activating mutation of TSH receptor. The receptors which are available onto the thyroid gland cells, they are the thyroid stimulating hormone receptor. But certain mutation of certain type of the mutation occurs, the other mutated gene, other mutated molecules, they are binding with the TSH receptor and functioning same as that of the TSH. Ultimately, the actual TSH is not there, but other mutated molecules, they are behaving same as that of the TSH. Ultimately, it will increase the thyroid gland cell activity. This is at the level of the primary, and at secondary, the pituitary cause secrete excess of thyroid stimulating hormone. Extrathyroidal cause exist. Extrathyroidal cause may be that is the excess administration of the thyroid hormone, or some anatomical distribution of the some tissues like lingual thyroid. So that will lead to the secondary hyperthyroidism. So both together finally will lead to increase the thyroid hormone concentration in the plasma more, and ultimately this situation is known as the hyperthyroidism that will have the effect. Uh, so these are the effects are there of the. Now what are the features are there? Okay, the how the patient feels, what happened to the patient, sign and symptoms are there. The clinical manifestations of the hyperthyroid patient, sudden loss of thyroid hormone activities increases the auto utilization and ultimately increases the uh, body temperature, that will lead to decrease all the protein catabolic activity, increase in the lipolysis. Ultimately, that will lead to the loss of weight, and that will lead to increase the excessive food intake. So these are the manifestations of the hyperthyroid person. Because of the beta receptors and sensitivity to beta receptors are increased at the nodal tissue, that will lead to increase the heart rate. So that will goes to the tachycardia. Arrhythmia or irregular heart rate, pounding or racing the heartbeat, palpitations are there, increased appetite, insomnia because of the neuronal system which is irritating continuously because of the concentration of the hyperthyroid condition. Astrocytes are there into the brain, that will have a deadenase activity utilizing the thyroid hormone. So that will lead to the irritation. So ultimately, person cannot sleep properly. Uh, the thyroid gland can be seen enlarged one in the neck region, nervousness, anxiety, the fine tremors of the finger because of the neuronal irritations, excessive sweating because of the temperature is increases, and vasodilation at the peripheral, heat intolerance. The person feels more heat than compared to the normal individual because of the J motility is increases. The frequent bowels are there. Easy fatigability because of the protein catabolism activity, that will lead to the muscle weakness. So you can see, this is the photograph of the exophthalmus. You can see the eyeball is coming out, that is known as the exophthalmus, and that happens due to because of the the soft tissues behind these eyeballs is swollen. The volume of the soft tissue behind the eyeball is increases. So this soft tissue volume is increases, that will lead to increase the pressure into the onto the eyeballs, and this eyeball are uh, looking like this, known as the exophthalmos. Uh, Now here you can see when the hypothyroid condition, when the hyperthyroid condition is there, and the hyperthyroid condition, if this is the situation occurs, when there is a thyroid hormone level is higher side, and that will increase the nutrients utility and increase the body temperature, because of the basal metabolic rate is increased, BMR is increased. So that will increase the body temperature is around 40 degree centigrade, 104 degree Fahrenheit. This is maintained when the thyroid hormone level is increases. So that will lead to the fast and irregular heartbeat, vomiting, diarrhea, agitation, heart failure. Because of the high temperature, this will this situation will occur very rare in individual, but these are the features occurs and may occur, and myocardial infarction is encountered. So higher temperature, all the tissues in the body, they may not cooperate with the function. Ultimately, this will lead to the individual to death. So death may occur despite the treatment is there. So this type of situation occurs in the patient known as the thyroid storm or thyrotoxic crisis is there. The another term is used as uh, thyrotoxicosis. Thyrotoxicosis, that is seen in Graves' disease. And Graves' disease, I think, just a minute. Okay, Graves' disease. So in the Graves' disease, the toxic multinodular goiter and toxic adenoma, that will lead to increase the thyroid hormone synthesis and secretion. Ultimately, that type of the hyperthyroid situation is known as the thyrotoxicosis, and that this type of the patient known as the suffering from the Graves' disease. So Graves' disease is a condition in which there is a diffuse enlargement of the thyroid gland, and that will lead to associated with the exophthalmos. This is the situation of the eyeball which is coming out, and eyelid is not completely up here. It cannot be closed properly. So this type of the situation occurs known as the Graves' disease, and Graves' disease is an autoimmune disease or due to the development of the autoantibodies against TSH receptors, and becomes hypertrophied and hyperactive. In these patients, the T3 and T4 is very high, and TSH concentration is less because of the negative feedback mechanism. The exophthalmos occurs, that is due to the swelling of extraocular muscles and proliferation of connecting tissues within the body walls of the orbit that pushes the eyeball forward, and this disease is treated by the antithyroid drug. So this is the hyperthyroid conditions are there, and if there is an extreme situation occurs, that is known as the thyroid storm. Now, how it will be treated? What will be the clinical conditions? Now, when it is estimated, when the blood sample is taken and T3, T4, and TSH is estimated in the plasma, that if it is a primary, if it is a primary condition, that means the thyroid gland itself is responsible for this. That is, in this situation, T3, T4 is high estimated and TSH level is low estimated. And if secondary hypothalamus means hypothalamus and the interpituitary is involved, then TSH is high along with the T3 and T4. So you can identify with this plasma estimation, blood estimation, the T3 TSH estimation through the blood sample. Now, physiological basis of treatment, the anti-thyroid drugs can be given to the individual. Anti-thyroid drugs, this is the which drugs are going compound related to the thyroid, thionamides. These thionamides, what it will do? The thionamides, these are the group of compound related to thyroid. This will lead, they inhibit the function of the thyroid peroxidase. These thionamides, this will inhibit the function of thyroid peroxidase. It inhibits the oxidation and organification of the iodide. It inhibits the iodine. Inhibits the iodination and MIT and coupling reaction. It reduces the level of the thyroid stimulating antibodies, and also it reduces the rate of the conversion of T4 to T3. So by inhibiting the T2 deiodinase activity. So these are the compounds are given. So ultimately the thyroid hormone maturation will be minimized. Ultimately thyroid hormone secretion will be less. It inhibits the function of the thyroid peroxidase that already I told you, inhibit the oxidation and organification of iodide, and these are the five things are there in which the anti-thyroid drugs are functioning. Ultimately, the T3 concentration in the plasma is decreased. The anions are also given. The anions, the chlorate, perchlorate, and pertechnetate are given. So they are competing with the iodine to bind with the sodium iodide symbol. Ultimately, the less iodine will enter into the cell. Ultimately, the thyroid hormone synthesis will be less. Another treatment is the high dose of iodide. If high dose of iodide is given, then this iodine itself is inhibiting the synthesis of the thyroid hormone. That is known as the Wolff-Chaikoff effect. So this Wolff, to produce the Wolff-Chaikoff effect, at least 2 milligram iodine per day should be given to the individual. So if it is 2 milligram and above iodine per day, if it is given, then it will inhibit itself all the steps of the thyroid hormone synthesis, known as the Wolff-Chaikoff effect. And the beta blocker is also given because thyroid hormone increases the beta receptors into the nodal tissue and onto the cardiac muscles, and it also increases the sensitivity of the catecholamine. So this beta blocker molecule known as the propranolol drug is given. So ultimately the activity of the thyroid hormone is decreases. It will reduce the stroke volume as well as the heart rate. And radioiodine progressive destruction of thyroids. So this is about the hyperthyroidism, and then just 5 minutes I'll finish the class. The hypothyroidism. In hypothyroidism, how it is identified: primary and secondary. Primary means gland itself is involved, and secondary means hypothalamus or anti-pituitary is involved. When the blood sample is taken and estimated the T3, T4, and TSH, in primary, T3 and T4 level are decreased, but TSH level is increased. And in secondary, TSH concentration is less in addition to T3 and T4. All three are less. Now, hypothyroidism in adult known as myxedema, and in children known as cretinism. So, myxedema, primary hypothyroidism. It is autoimmune hypothyroidism known as the Hashimoto thyroid disease. These are the molecules which are functioning over here, inhibiting the activity of the thyroid gland cell. Ultimately, the thyroid gland is not functioning well, and these autoimmune molecules that will lead to the inhibiting or suppressing the function of the thyroid gland cells or synthesis of the thyroid hormone. So this is condition known as the Hashimoto thyroid disease. These antibodies formed against thyroglobulin and TP. So these antibodies which are formed, and thyroglobulin is very important molecule, and TPO, the enzyme, is also important. So these autoimmune antibodies, these are inhibiting this activity. Excess use of radioiodine, that will also cause the suppress of the thyroid gland cell. Iodine deficiency, that will lead to the goiter. You can see in the photograph over here. Excess use of anti-thyroid drugs also that will lead to the suppression of the function of the thyroid gland, and congenital hypothyroidism, that is the genetic uh, congenital activity. Secondary, that means hypothalamus and antipituitary. The pituitary hypothyroidism, if pituitary neurons, pituitary thyrotropes are not functioning well, then there is not enough TSH is available, so thyroid gland cell will not function. Hypothalamic hypothyroidism, that means the neurons in the hypothalamus is not synthesizing or releasing the TRH. Ultimately, the TSH will not be secreted, and ultimately T3, T4 will not be there, and thyroid hormone resistance. So this black and white photograph is the myxedema. This is the goiter, and this is the cretinism. Cretinism is dwarf and mentally retarded. If the thyroid hormone is not enough in concentration available, that I have told you, the thyroid hormone is required for the development of the brain. Most crucial is 6 months before birth and 6 months after birth. During this time period and after that also, if the deficiency of the thyroid hormone takes place, then this will not help to development of the all parts of the brain. Ultimately, the neurons are not developing. There is no communication between the neurons. Ultimately, that will lead to the mentally retarded. So hypothyroid features are the psychological signs and symptoms of the hypothyroid person: poor memory and concentration, poor hearing, the hoarseness of voice, slow pulse rate, pericardial effusion, delayed reflex relaxation at muscular level, heart level, slow pulse rate, the bradycardia will be there, extremities coldness, carpal tunnel syndrome, because of this. In general, fatigue, feeling cold, weight gain with poor appetite, hair loss, lungs, soreness of breath, pleural effusion, and skin paresthesis. The receptors are not developing well. The myxedema, intestine, constipation, ascites, and reproductive system mineral resistance. So these are all the abnormalities of this uh, hypothyroid condition. So here in this, the symptoms are the cold intolerance, weakness, and easy tiredness. These are the important features are here. The GI motility is decreased, that is the constipation, weight gain, and diagnosis is the disease over the phone. This can be diagnosed over the phone also. So this is about the hypothyroidism. This is the photograph. You can see this hyperthyroidism and hypothyroidism. The hyperthyroidism even in the intolerance to heat, and hypothyroidism intolerance to cold. Now the thyroid function test. The thyroid function test, what are the tests to be done? The measurement of the thyroid hormone, the plasma TSH estimation can be done, measurement of binding proteins can be done, TRH response test, detection of thyroid antibodies, plasma cholesterol, estimation of the, because all these the functions in function of thyroid hormone I have explained in detail, so I am not explaining over here. Estimation of BMR and decreased relaxation time. So these are the tests to be done for the abnormality of the thyroid functions. So I think, and one thing is that if there is, if the hypothyroid status is found earlier, then the thyroid treatment is good. Here you can see thyroid treatment is good. So the mental age, the born age, the height age, and mental age, this can be increased over here. You can see this chronological age of the normal individual, and this is the individual in the normal. So thyroid, when the thyroid treatment is done, when it is uh, normally found in the normal. So here about the thyroid hormone is over, and now I'm closing the class. So now I'm closing the class. You can leave the class for the next class.